So welcome back. Thank you very much for this first part of the conference. It was really, really interesting. So the last speaker for this morning is Richard D'Aquila. I'm really welcome you to Cyrano. So Mr. D'Aquila is the president of Yale New Haven Hospital and Yale New Haven Health System in Connecticut. He's responsible for day-to-day operation of Yale New Haven hospitals with an operating budget of 2.5 billion and over 12,000 employees and 4,000 medical staff members. In October 2016, he assumed responsibility for system-wide ambulatory and service line strategies, as well as medical staff and nursing integration across the health system. Thank you very much for being here today.
So thank you, and good morning, everybody. And it is a privilege to be here. What I'm really going to do is just very quickly touch on our environment, which is very much like the perfect storm that the previous speaker spoke to. I'm going to talk about health system integration, and then really use our case study to really kind of go through what are the challenges that we faced as an organization, as a health system, and how have we evolved, and what have we learned really from that process. And I'll tell you now, and I'll remind you at the very end, we're still learning. It is a work in progress. You're never there on so many fronts, and there's no one solution that fits every circumstance. And so you really have to embrace the whole concept of lifelong learning and learning from your mistakes. So these are our challenges. This is our perfect storm. This is what's happening in the United States. This is what's happening in Connecticut, where we are. A lot of it is being driven by simply the scarcity of resources and the economic challenges that we're facing. We are also moving as an industry and as healthcare providers from this concept of volume to value. Still very much in a world where we're being paid for volume, but much inappropriately moving into a world where we're paid and at risk for health outcomes. And the rest of these are going to look very familiar. There is enormous potential and cost of technology. There's really a looming scarcity of providers, particularly experienced providers. And there is an appreciation for the fact, and I'll spend time on it later, that we must continue to optimize the clinical care that we provide. Again, I won't spend a lot of time on this. You saw other slides that speak to the increase in healthcare spending, and certainly when you combine that with the demographics that we're all facing, and it's unsustainable. So not surprisingly, we're seeing a lot of consolidation in the States. And these are just some of the data that show the trends of what are emerging in terms of health systems or consolidation efforts among healthcare providers. You know, what's really driving this, and what are the compelling reasons for building these affiliated structures? A lot of it has to do with the ability to share scarce resources. I'll touch on some of that, and drive efficiencies through scale. Much of it is focused on how can we more critically preserve and grow access. These patients that are in our acute care system are sicker, more complex, much more multidimensional in their care. This is an opportunity to critically preserve and grow access. The payment cuts are staggering, both at the federal level and at the state levels. Particularly now, there's a lot of uncertainty, and that really affects organizations like ours, which are safety net organizations. Yale New Haven Health, as many nonprofit organizations, takes every patient regardless of ability to pay. And while we have federal and state funding sources, they are evaporating. In some cases, in state funding sources, we're paid about 29 cents on the dollar of cost. So my folks remind me we only have 29 cents more to go, and then we're providing care for free. It's daunting and an incredible challenge. And again, the rest of these reasons you are familiar with. I want to start with a premise or an observation that there is a lot happening in our industry, a lot of consolidation. There's not a lot of true integration. And the rest of my comments are really going to focus on and try and create a construct for very much the difference between the two. And so what I'd like to put out there from our perspective is that what we have tried to build and aspire to evolve is a health system that has a number of critical characteristics that define integration. One is that we do build a structure that is focused on patients' clinical needs across the entire continuum. And there are a lot of elements in there. And I'll show you a framework in a minute. Organizational structure is critical. Focusing on the patient is critical, and the concept of continuum, if you heard from others, is particularly important. That you build things that create strong multidisciplinary collaboration. Most of our institutions and many of our systems are built around departments and structures that are for the convenience of the providers or the educators, and not the care systems that patients benefit from. And I'll spend some more time on that. We really strive for a care signature that is focused on outstanding clinical outcomes across the entire continuum. But this concept of one standard of care across a health system is critically important. I'll spend time on electronic medical record, but of course underneath it is the value of the ability to communicate, for all providers to communicate across a health system, for the patient to dock into that, and for vitally important functions like medication reconciliation to occur is absolutely critical to have that backbone. You have to have engaged employees and physicians. We deal with burnout. We deal with career focus. And you have to constantly focus on getting better and reducing waste and improving outcomes. Our challenges would be much less if all we had to do was get less expensive as an industry. But the reality is, or a system, the reality is we have to get much better outcomes, sicker patients, and we have to reduce or eliminate waste. So here's the framework that I'm going to use to talk about our experience. I'm going to talk about 8 dimensions of how we built our health system. I'm going to talk about our organizational structure and how we use service lines as a framework to define care systems around patients. I'm going to talk about high reliability, which is a multi-year focus on minimizing, eliminating events of harm for patients as one of the critical elements to bind folks together around patient care. I'm going to talk about the patient experience and what it looks like from the patient's perspective. Our efforts to build a broad and diverse ambulatory strategy, the entire continuum of care across, in our case, a broad geographic area that is over 5.5 million people. We'll, of course, talk about the medical record. We'll talk about something that I think there's a lot of enthusiasm for, and that is telemedicine, and use actual examples of how we're using telemedicine to provide that signature standard of care across a health system. Clinical redesign, the work that is constantly improving, producing better outcomes, waste reduction, and more engaged physicians and staff. And then how we align incentives across our health system, how we get everybody, literally 40,000 plus people, focusing on the same things in a very broad and diverse health system. So our case study, a little bit about us. We are a health system serving Southern Connecticut, Southern New England, 5 hospitals, about 2,500 licensed beds. We are the Yale New Haven Hospital is the primary teaching hospital of the Yale School of Medicine. And there's a lot of other things in our health system. I realized, especially when I heard the other speakers today, that I left off a number of important parts. We are physician foundations. We're medical homes. We're primary care groups that have built really impressive case care management programs and disease management programs. We're home care and we're long-term care. But for the purposes of today's discussion, what we really wanted to put up there was how we brought these hospitals and this health system together with a focus on acute care. Yale New Haven Hospital is the cornerstone. It is a quaternary referral center. It is a destination hospital. So we have built signature programs around being a trauma center. Our work with living donor transplantation, our work with the university around genomics and applying genomics into healthcare. Some very unique tertiary services, our ability to provide ECMO across the tri-state region. Some of the things that we're doing with neurovascular and other clinical innovations. We have something called a transfer center called Y-Access, which is manned 24/7 and is organized for any physician anywhere to talk to a healthcare trained individual who can manage the transfer, the bed assignment, and the clinical consultation with a physician specialist within a matter of minutes. And in fact, we receive 20 plus patients a day, over 600 a month. That number grows every month, and again, those patients are accepted without regard for ability to pay. And then I'll talk about tele-ICU and telemedicine. But we are, Yale New Haven is really the core of this network, but what we're trying to do with our health system is drive that level of care out across a broad geographic area and all of the institutions that are part of Yale New Haven Health. Yale New Haven Hospital, by the way, is a very large hospital, now over 1,500 beds, and it was the product of two hospitals in New Haven, Connecticut, which ultimately merged, which is very unusual in our regulatory environment. But because of the statewide and regional market of Yale New Haven Hospital, the federal regulators allowed that merger to take place. What's important about that merger is we were able to take two campuses, literally blocks apart, and rationalize services across two campuses and deal with where is heart surgery done, where is cancer care done, which is the trauma center, which is musculoskeletal. And I say that only because I wish it was possible to do that all the time, because it made it easier when it was one hospital, one license, one regulatory mandate. That's not the world the rest of us live in. But that one was sure, although it was complicated, it was much easier to deal with the issues of who does what and how do you share and how do you truly integrate services and rationalize care. So it was certainly we learned a lot from that exercise. When I saw the VA statistics, I realized how small and insignificant we were. But it looked pretty big up until that point. This is who we are, and we are extraordinarily busy with a lot of pressure on inpatient and ambulatory capacity. So let me talk about the 8 building blocks and kind of what we did in each of these areas to build this health system. And the first is organizational structure. We are organized, again, several hospitals. So I know what's going to go down. Several hospitals and large, diverse medical staffs, faculty, non-faculty, private foundations. And there are some elements of our structure we think are unique. One is there is an individual who is responsible. Now it's me, so I have no one else to blame. For driving clinical and program integration across the entire health system. Under my auspices and in our structure, all of the service lines, all of the clinical programs, all of the ambulatory strategy that is embedded within that, all of the medical leadership and all of the nursing leadership is under my sphere of responsibility. And not from a control perspective, but rather from an integration perspective. Within that role, there are standards for service lines, there are standards for medical practice, There are standards for nursing recruitment across an entire health system. So I can come back and clarify that with questions. We are organized along service lines, and I'll give you an example of that in a minute. But within a large system, what service lines do is create a structure where there's both an administrative, a philosophical, and a strategic structure, and an operational structure for how clinical services are run within the health system. And we have 6 of them, and they are characterized by the fact that they are multidisciplinary. Our musculoskeletal service line is an amalgamation of orthopedics, spine care, movement disorders, physical medicine, rehabilitation engineering, pain management, rheumatology. They're collected administratively in an operating structure that is different than, very different than the traditional academic medical center structure. Our cancer hospital, radiation therapy, medical oncology, surgical oncology. So that is, in order to be structured as a service line in our health system, that element of multidisciplinarity has to be in place. But there has to be a lot more. There is, in our system, there is a leadership executive who reports to me, who has full responsibility for all of the metrics of service line performance. He or she is the strategic leader. He or she owns the numbers that matter, the profit and loss statement, the margin responsibility, the growth strategy, the quality indicators, the safety indicators, the patient satisfaction metrics. That individual is responsible for all dimensions of performance. And when I talk about aligned incentives at the end, I'll connect that to even what happens to staff members as they receive their incentive increases at the end of the year. This is our cancer hospital. The idea behind another really critical idea behind service lines is service rationalization. That the breadth and depth of a cancer hospital serves an entire geographic region. And it's not duplicated at member hospitals. It is backed by a statewide network of ambulatory services. It is connected with clinical trials. It makes investments in services like complementary and alternative medicine. It has many people deep in each of the clinical disease areas. And it makes investments in things like applied genomics that no one institution could rationalize as an investment, but for an entire health system, a genomic center is I would argue, an essential for part of much of the care we provide. Neurosciences, a similar framework. Again, the center for complex clinical care is at the Yale New Haven, but it connects to a network across the state with telestroke units, rehabilitation programs, and vibrant surgical and medical programs in each of our clinical facilities. So again, just to give a sense that it is about taking the clinical area, rationalizing care or along a broad geographic region, pushing care out to the community and into ambulatory services, but doing it in a way that is rational clinically. So that's the first area that I think is critically important, is how you organize services across a broad continuum. High reliability is the second. It is getting everyone to have a literally obsessive focus on eliminating events of harm. That means training each and every staff member, in some cases up to 8 hours, every member of the medical staff on literally the basics of what causes patient harm. And there are groups like IHI that come from the nuclear industry or from aviation that really take every staff member through. We're all trainers, including myself, of all the elements of how to recognize high-risk situations, how to stop the line, how to learn from mistakes, and how to focus on eliminating events of harm. And they are a series of behaviors and a series of principles that every employee has to live by. Voicing concerns, feeling empowered to stop when communication isn't clear, and exhibiting a set of behaviors that folks are held accountable for. I'm proud of these numbers. It shows these are 12-month serious safety events in our hospital. In our hospital, in the last 12 months, there have been no events of harm in our children's hospital or in our psychiatric hospital, and 48 events across the entire year for the entire 1,500-bed, 1.3 million outpatient visit hospital. So again, just like the organizational structure, I think the second critical element is how everybody focuses on eliminating events of harm, and everybody has a role to play in that. Third element is the patient experience, and very much related, particularly to high reliability, is how we educate and hold staff accountable for the behaviors and the expectations around patient experience. And it isn't just the experience patients have when they're receiving care. And in our market, that still is one where patients have choice, and where each generation thinks differently about how they access care. It's actually the entire continuum. Can they find us? This is an advisory board framework. Can they find us easily? Can they access our services immediately? Is the entire encounter, does it meet their expectation, including the bill, which can be a huge dissatisfier for our patients? And then what have we built as a retention strategy for patients to stay loyal to our healthcare system? And again, we're still in a highly competitive environment, but building this kind of patient expectation around the care you're going to provide, we believe is critically important. There are standards and guiding principles. Again, these standards of behavior and this level of staff orientation is how our staff are educated and held accountable for what patients expect from them, and what their role is in communicating with patients and families. Fourth element is our ambulatory strategy. Again, I defined a very broad area of about 5+ million people, and we are building an ambulatory strategy, building on some critical elements of ambulatory facilities. We have kind of big boxes, if you will, that are literally everything but beds, surgical facilities, emergency departments, radiation therapy, oncology. We have smaller boxes that are community-based centers where heart failure, basic cancer care management is provided, and they are dispersed in a broad geographic area, linked electronically, but kind of one common vision and one, again, set of standards of care. And we're in the process of building that as more and more care we expect will move to the ambulatory environment. That has not been our experience to date. We are still enormously pressured for beds and critical care capabilities, but our goal is to push as much as possible into an ambulatory care network. I want to spend a little bit of time about electronic medical record. It's a huge investment. It is, it's hard to say which one of these is the most important, but a lot of this you cannot do if you do not have an integrated electronic medical record. And it's more than what I said. I said it earlier. It's a communication device. It's a critical mechanism for the entire continuum of care to communicate. It's now a great way for patients to be involved in their care and being able to do everything from book appointments to participate in the care process. I won't spend a lot of time on this. It's very connected. Our provider is Epic. It's one of several strong systems that are out there, and it links all of the elements of our healthcare systems, our physicians, our diagnostic and testing capabilities, our inpatient care, all of our critical care facilities, and it does it in a variety of different ways. And it does it with a variety of different devices. We have, like everyone else, a lot of very smart technology that is increasingly complex at the bedside and out in the community, and now even in the home. And Epic does that device integration. It also provides our patients with the ability to access their chart with something called My Chart, and not just request appointments, but populate data on their care. You know, their dialysis, their home dialysis flow sheets, their diabetic testing. There's an enormous amount of capabilities for the patient to participate. We have our patients who are transplant patients have their pre and post visits via an accessory to this with an iPad rather than to meet constantly with their providers. And then a lot of devices. WOWs are workstations on wheels. Mobile Heartbeat is an iPhone-based technology that all of them navigate the patient medical record, allow the providers to communicate, and test results to be observed. So there's a huge investment here, and it's a critical backbone for our system. Also want to spend a couple of minutes on telemedicine. Telemedicine is something that we have found really helps us rationalize services across our health system. It grew up with concepts like telestroke, where a stroke neurologist team in a bunker had video feed access to emergency departments across our network hospitals and even non-network hospitals, because telestroke provided the ability for even competing hospitals to provide one standard of care that has an amazing success record of patient saves. What has grown out of that is the concept of teleconsultation and tele-ICU. And we have a functioning EICU. I'll show you an overview of it in a minute, which provides the ability to take concepts like telestroke, one very specialized group of clinicians linked to technology, spread across a broad geographic area, and build on that with other scarce resources like physician intensivists. And the goal, again, is all about the patient, providing one standard of care across a broad geography, whether you're in an outlying community hospital or whether you're in an academic medical center. This is what it looks like. These are the video feeds and the panels that access this information. This is what the patient view looks like. There is complete physiologic monitoring. There's high-def video monitoring, and there's two-way communication between the provider team with the patient in full view for this kind of information at the bedside. And again, our team feels passionate that there are data that support tremendous advances in patient outcome, and our ability to curtail the number of rapid responses, the patients that descend into crisis when you have capabilities like this embedded in your health system. Teleconsultation is physician to physician, and now physician to physician to physician to patient consultation. The possibilities here are endless. We have groups working on incredibly scarce areas like child psychiatry and their ability to have access to teleconsultation. As I said earlier, we have transplant patients going home with iPads and not having to come back week after week for follow-up visits. We have rehab patients post joint surgery who go home with an iPad that takes them through their exercise regimen. And after I had my surgery, they can't get away from, because the iPad's keeping an eye on them and taking them through an exercise regimen. The capabilities are incredible. Last couple areas I want to focus on are clinical redesign, and I don't want to minimize this. Clinical redesign for us is going back to what I said about improving outcomes, eliminating waste, has been the primary way we have engaged our physicians in dealing with our cost crisis, because there is an incredible opportunity to get them excited about producing better outcomes and lower costs. Nobody gets excited about just lower cost. And we have a structure where teams convene, look for those opportunities, engage process improvement support, Lean Six Sigma, test results, implement change. We give them broad authority to make changes in clinical protocol and process redesign. They even publish their findings, and it has been a tremendous way of engaging our physicians, but again, more importantly, producing true value for patients, better outcomes, minimize waste. These are just some of the teams that have accomplished this kind of work. At any point in time, we have 20 teams chartered in our health system in the process of clinical redesign. And again, just some of the results. There are many, many of these, the work of these teams. And here, here is the twins of reduced days and adverse events avoided, which are some of the critical benchmarks. And it does save a lot of money by eliminating waste. Last thing I want to comment on is how do you get everybody rowing in the same direction? Again, in our health system, what we've adopted is a framework that there are 4 basic categories of success factors. Patient safety and quality, very defined metrics. The patient experience, patient satisfaction, very defined metrics. Workforce engagement, what we look for in terms of physician and medical staff engagement, and our financial performance, that we generate sufficient margin to invest back into our organization. Whether you are a member of the executive team or whether you're a frontline employee, you are held to the same metrics in terms of your comp. We give our employees an annual increase based on performance, and then a increase that ties to this organizational performance. So when I talk with frontline employees, they want to talk about CAUTIs and CLAPSIs and falls with injury, because those are our, as an entire team, those are our standards for patient safety, and they're all weighted the same. So it really kind of levels the conversation about why we've built a system, why we provide infrastructure, what we're all working towards as a healthcare team. So what do we learn from all this? Well, we made a lot of mistakes, and we've used that in still being persistent and working towards better models and better success. There's no substitute for full integration. What I described with St. Raphael's was, again, tremendous to be able to take one organization or a number of organizations and move them together with common purpose and common operating authority. It's just never quite that simple. I think you need all these pieces to be successful. You need the structure, you need the medical record, you need the incentive alignment, you need the focus on high reliability. They're all elements of, and you saw it with some of the previous speakers, of what facilitates integration. You need to have broad engagement and support. Sounds pretty obvious. This takes an enormous and relentless effort at communication. Everyone has to understand why it's in their best interest and in the patient's best interest for the organization to be structured this way, and for people to move away from their structures and their comfort zone to deliver care this way. The patient's at the heart of it. And as I said when I opened, this is a constant evolution. We're a work in progress. This size doesn't fit everybody, but we are committed to improving it each and every day. So with that, I'll stop, and I don't know if you want me to take any questions.
Yes, sure. Thank you.
Question with respect to service line integration. So when you looked at, say, cancer care as an example, what were the main challenges that you faced in building integration across the hospitals and out to the sort of more primary care areas, and how did you overcome those obstacles?
So it's embedded in every service line. It is resistance to an overarching structure. It is, in our case, private physician groups who were community practitioners and not part of the academic health system. And I think those were, and just kind of the identity of the individual hospitals. We achieved it by convincing them, which I honestly believe, that if we're going to compete and deliver service that is as great as or better than Sloan Kettering or Dana-Farber, who are our neighbors to the north and the south, the only way that's going to happen is if you're part of a true comprehensive cancer center, and that it has all the elements that I described, and that it wouldn't disenfranchise community physicians. In fact, they'd be engaged, they'd be part of clinical trials. But again, it was really painting, one, that's the standard of care that patients have the right to expect, that patients shouldn't have to leave our state to achieve that care, and that they could be part of it without being in a way that was collaborative. And that has continued to evolve to the point where virtually all of them now have come on faculty on the cancer center, and there will be very distinct standards of care and protocols.
Thanks for that great talk. So can you say a little bit about the competitive environment and how that helps or hurts you in creating this integration?
Well, it's a great question. The competitive environment, it creates, there are two things that create a great crisis for us. One is the competitive environment, and the other is the financial environment. I think it is much more essential and urgent to create solutions like this, and easier to overcome the obstacles. People want to do the right thing, but it's hard to sense the urgency of it until there is either a competitive or a financial threat. And we have both of those. And so I think it has helped us kind of create, the joke, don't waste a good crisis. But, all the data that we are all familiar with about the unsustainability of this, it honestly goes in one ear and out the other. It is not relevant to the practitioner or to the individual until they either can't get the care they expect or they can't afford it. And that has helped us accelerate integration. Yes.
Thank you very much for that. I work as a practicing internist in one of our major teaching hospitals, but also have a major daytime job as a vice dean at McGill University. Have you, and how could you, and how should you have the university affiliate, the university with which you are affiliated, be a facilitator in this process, which has noble objectives, but which is very challenging? Has this happened in your case?
It has, and they are my partners. So we are corporately separate from Yale School of Medicine, but we are their primary teaching hospital, and really respect everything that academic medicine brings to the equation. I couldn't do this without Yale School of Medicine. And what we've really done with them is use them to help build the specialty framework, recruit the specialists, develop the evidence-based protocols, and really engage them. What we've not used them for is primary care. We have looked to other sources too. We have our own primary care foundation. We work exclusively with large primary care groups. We've tried to balance what the university brings to the equation with the reality of what the market brings to the equation, and hope for peaceful coexistence. So far, so good.
One question. Just a question about the telemedicine. The specialists are talking to the physicians who are in your satellite area. Are the patients and families
Yes,
involved in that?
they are. The primary communication takes place at the bedside, and then there's also a feed to the patient care support areas. But the patients know there's actually very strict guidelines for when the camera is on. The patients know. Patients actually love it. The families love the fact that there's no fear of privacy or intrusion, that a team of intensivists is watching over their loved one, and it's been well accepted by families. Thank you all.